Hello everyone, today let's talk about bladder and its disorders. Now the urinary bladder per se is a storage organ. Any disease of the urinary bladder or any treatment modality that you do on the urinary bladder is not just like any other urological organ. That is because any problem with the bladder can have a major implication on the quality of life that the patient has. So let's assume the bladder is emptying very soon, okay, because of whatever reason, either the bladder has become small or it's a neurogenic bladder, whatever it is. Imagine having to run to the washroom every 10 minutes. It's a very embarrassing and a very difficult scenario for the patient. At the same time, let's assume the patient is unable to void. He goes into retention. Now, even that is also an equally embarrassing or a equally disturbing problem for the patient. On the other hand, let us talk about certain malignant disorders of the bladder. So imagine having to remove the bladder and the patient being unable to void urine, they'll end up having a stoma, one or the other thing. So it is something that can have a major implication on the quality of life that the patient has going forward. So having said this, let us talk about some common bladder disorders. So first we will be discussing about benign bladder disorders and then we will wind it up with the malignant bladder disorders. So talking about benign bladder disorders, the first thing that we're going to discuss about is bladder calculi or bladder stones. So here you can see in this image, these are stones inside the urinary bladder. Okay. Now these bladder calculi can be classified as primary and secondary. Now anywhere else in the body, primary and secondary basically kind of tell you the source. Okay. Now going by the definition, primary means something that is developed within the bladder, secondary means something that is developed in the kidney and then it comes down. But that does not apply here. Okay, that does not apply here. Primary means in a sterile urine because of no other issues, if a stone develops, that's called as a primary urinary bladder stone. Secondary urinary bladder stone or a secondary bladder calculi, here because of certain problems of the urinary bladder, okay, either secondary to infection or secondary to an obstruction which causes stasis of the urine, and then if a stone forms, then you're going to call it as a secondary bladder calculi. So primary means there is no underlying disease of the bladder. Secondary means there is some underlying disease of the urinary bladder which has led to the formation of a stone. So a quick recap. In primary, there is no issue, so there will be no distal obstruction. Okay, male more common than female with regards to the primary bladder calculi, and it's more commonly seen in children. Okay, more commonly seen in children. And if you look at the content of the stone, it is a ammonium urate stone. And once you deal with the stone, because this is a primary urinary bladder, something that has just happened without any effects of the bladder, once you have removed the stone, there is no reason for the stone to come back. Okay, at least in secondary bladder calculi, if you don't deal with the actual cause which has led to the stone, the patient can have a recurrence. So here recurrence is very, very rare. On the other hand, when we talk about the secondary urinary bladder calculi, here most of the times there is a distal obstruction that is there, okay, or because of some sort of infection, okay, urinary infection. So these two conditions can lead to formation of a stone in the urinary bladder, and that is what we call as a secondary bladder calculi. Now here the patients who are commonly involved are the elderly patients. Simple common sense, distal urinary tract obstruction, most common is benign prostatic hypertrophy. BPH is more common in young or elderly patients. It is more common in elderly patients. So just remember that secondary bladder calculi is more common in elderly patients. Now if you look at the component of the stones, it can either be a uric acid stone or it can be a struvite stone. Now if it's a BPH or an obstruction, then it is probably a uric acid stone. Whereas if it is secondary to an infection, okay, and we have already covered this when we spoke about renal calculi. In the presence of infection, the most common stone that you're going to come across is the triple phosphate stone or the struvite stone. Okay, the struvite or the triple phosphate stone. And recurrence is common here unless you deal with the actual problem, which was either the distal obstruction or the urinary tract infection. So unless you treat these two conditions, there is a very high chance that this stone will recur. Okay. Now this primary bladder calculi, I told you there is no obvious cause as to why the stone forms. So one of the hypotheses is that it is probably because of some issue with the nutrition and the hydration. Okay, nutrition and the hydration. That means because of loss of certain elements in the diet, or the patient is not hydrating themselves adequately. That was one of the reasons why they thought that is the cause for your primary bladder calculi. Now, if you look back at that, if it is something to do with the nutrition, it should be something like your thyroid disorders, correct? Like in a particular belt, there is a lack of iodine, and that is why it has led to goiter. So they found that this primary bladder calculi also happened in a certain geographical area. Okay, so that is why they started calling it as a endemic calculi. Endemic calculi because there was some nutritional imbalance in that particular locality which kept leading to the formation of a primary bladder calculi. So how do these patients present you? The most characteristic feature is terminal hematuria. Now terminal hematuria basically means at the end of the act of micturition, there is blood which comes. Nothing great about it. Okay, just imagine there is a stone, the stone is floating inside a bladder full of urine. As the urine empties, the stone will keep coming down, it will start hitting the base of the bladder or near the neck of the bladder, and it will scratch. That is when it causes bleeding. So if the bleeding has to happen, the bladder must be empty. If the bladder is filled with urine, the stone will keep floating or will keep moving here and there, so it won't cause much damage or scratches. Okay, so remember, at the end of micturition, the bladder calculi will rub the bladder neck, and thereby you will have few drops of blood that come out. That's why you'll have the blood at the end of the micturition. Apart from that, they can have burning micturition, urinary tract infection, or dysuria. All these are the possible associated symptoms with a bladder calculi. How are you going to diagnose these patients? A simple ultrasound of the abdomen and pelvis is more than sufficient. If you remember, in gallbladder stone, if there is something filled with calcium, there is a posterior acoustic shadowing. That means that area becomes blank. Okay, because the stone takes up most of the ultrasound waves, it doesn't allow anything to be transmitted behind it. So the area behind it becomes black in color. That's what we call as a posterior acoustic shadowing. Okay, so here also, if you do an ultrasonography, there will be posterior acoustic shadowing. So how are you going to treat these patients? Now the treatment is dependent upon the size. Okay, it is dependent upon the size. If it is less than 2 centimeters in size, you can do something called as a cystolitholopaxy. That means it is some surgery that you do through the transurethral route. Okay, transurethral route. So all you're going to do is you're going to go in, you're going to crush the stone, and you're going to come out, and all those powdered stone pieces will eventually come out through the urine. That is what we call as a cystolitholopaxy. Okay. On the other hand, if the stone size is more than 2 centimeters in size, then it becomes very difficult for you to even hold the stone and crush the stone. In such a scenario, it is better to do a open surgery, and that is called as an open cystolithotomy. That means open, that means almost like a mini laparotomy. Okay, make a small incision, isolate the bladder, pick up the bladder, make an incision on the bladder, open it, remove the stone, close the bladder, close the abdominal wall, and get out. That is what we call as a open cystolithotomy. One other thing that you need to know, there is a certain instrument that we use whenever we do this cystolitholopaxy. This is something like a cystoscope. Okay. Now that instrument is called as a lithotrite. Okay, this can be asked as an image-based question. So the stone is kind of held between the two jaws of the instrument, and then when you press it, it's going to crush the stone. So that will help you retrieve the fragments of the stone. Next condition we're going to talk about is that of a congenital condition. One of the most famous image-based questions, be it undergraduation, be it post-graduation, there is a very high chance this image might come up. Okay, and this condition is called as a exstrophy of the bladder along with the epispadias complex. So if you see in this particular image, the entire bladder is outside the abdomen. there is a deficient anterior urinary bladder wall. So what you're seeing is only the posterior bladder wall. So if it's the posterior bladder wall, theoretically you should be able to see the ureteric orifices as well, okay, and you will be able to see the urine dribbling down, okay, because it's not a complete urinary bladder. One half is gone off, the anterior part is deficient. So from the posterior, like a fountain, you'll see the urine dribbling down, and that is characteristic of a exstrophy of bladder and the epispadias complex. Now, like we already know, it is a congenital anomaly. Now, this Exstrophy-epispadias complex is a wide variety of diseases. Okay, it can be something to as simple as a simple epispadias. That means where the urethra opens at a much more proximal area rather than the urethral meatus. Okay, rather than the tip of the penis, if it opens proximally, that is what we call as a epispadias. Now, along with the epispadias, you can have multiple other problems. Something as dangerous as a condition that we call as a cloacal exstrophy. Okay, so remember, the smallest of this entire range of diseases or the entire variety of diseases is the epispadias, and the most dangerous or the most problematic condition that you can have is your cloacal exstrophy. And somewhere in between this is your Exstrophy-epispadias complex, and amongst this entire variety of diseases, the most common is your classical Exstrophy-epispadias complex. Okay, so something very simple to something very complex, and the most common in this entire variety is what we are discussing, that is your exstrophy of the bladder with an epispadias complex. So if you look at the pathology here, there is a protrusion of bladder through the anterior abdominal wall. Not only that, there can also be an associated abnormality of the bony pelvis, the pelvic floor, and the external genitalia. So it's not something that is only related to the bladder, it can also be associated with certain other problems. Now, what I am trying to tell you here is, just repair of the bladder might not be sufficient. You might have to do certain other procedures as well whenever you're treating this particular child or the patient. Another thing to be remembered here is that, see, bladder arises from what? The urogenital sinus. Correct? So, if there is some issue with the development of this urogenital sinus, that is what leads to your exstrophy. Now, along with this urogenital sinus, you will have certain skeletal muscle defects also. That is why the anterior abdominal wall is also missing. So, that is the embryology part. Now, one extra line that you guys need to know is that this particular condition has a higher risk of developing adenocarcinoma. Okay, adenocarcinoma of bladder. The reason why I am telling you this is, there are 3 histological subtypes of the urinary bladder. We will be talking about it in some time: transitional cell, squamous cell, and adenocarcinoma. Now, in Exstrophy-epispadias complex, there is a higher chance of the patient having a adenocarcinoma of the bladder. Now, what are the associations of this exstrophy of the bladder? There can be an absent anterior wall of the bladder. This we already know. There can be an absent anterior abdominal wall. Okay, abdominal wall is open, not just the bladder. Okay, and that is usually seen in the infraumbilical region. The posterior wall of the bladder is exposed and the urine is dribbling from the trigone, that means from the ureteric orifices. They can have pubic diastasis. Okay, pubic diastasis. The pubic rami, okay, are separated. Okay, separated pubic rami. Apart from that, in your cloacal exstrophy, that is the widest or the kind of major congenital abnormality that you can have. In those patients, there will even be an umbilical hernia and it can be associated with a rectal prolapse. In the regular condition, unlikely. That means in the classical exstrophy that we are talking about, unlikely to have these 2 problems. But if it's a cloacal exstrophy, very high chance you will find that. So in male patients, it is associated with epispadias, undescended testis, and a shallow scrotum. Whereas in a female patient, they can come with a bifold clitoris, and a widely separated labia. Why is the labia separated? Because even the pubic bone is separated. So automatically the labia tend to drift apart. So how do we treat these particular patients? That is with the help of a multi-staged treatment, which basically means there are a lot of things that have to be set right. Not everything should be set right in the same sitting. Why? Because the baby is still growing. So there will be certain changes in the dynamics. Okay. So don't try and repair everything in the same sitting. Wait for it. Whatever has to be repaired first has to be repaired, then eventually stepwise. And we'll see what are those various steps that are going to be performed. Now this is something similar to your cleft lip and cleft palate. There also you go in stages, right? You don't do everything in a single sitting. Something similar is carried out here as well. First thing to be done is bladder closure. Now that is followed by abdominal wall closure. So in abdominal wall closure, what's happened? The entire abdominal wall is drifted apart. That means your rectus abdominis muscle has kind of gone off. So the first thing that they're going to do is they will separate the rectus abdominis from its insertion onto the pubic bone. Okay. So they will separate it, bring it to the midline and stitch it up. Okay. Approximate the two recti muscle. That's how they're going to do an abdominal wall closure. Next procedure is a bladder neck repair. And finally after that, because you have kind of recreated the bladder, it would have usually shrunk. Sometimes you might have to try and increase the capacity of the bladder by performing a bladder augmentation. And the last repair you're going to do is a epispadias repair. Epispadias repair. This pubic osteotomy is usually done either with the first or the second procedure. Okay. There is no fixed rule as to when you have to do it. Sometimes, usually it is done within first year of life. Okay. That is your pubic osteotomy. But remember, the last one to be rectified is your epispadias. Okay. So the urethral issue is corrected in the last. Now let's talk about schistosomiasis of the bladder. Schistosomiasis is a parasitic infection. Of course, if it involves the bladder, then it becomes a parasitic inflammation of the bladder. Now there are 5 species of schistosomiasis, but you guys need to know only 3 because these are the 3 which infect the humans. And we are only bothered about what infects humans. We are not bothered about what infects the other species. Now in humans, you can have Schistosoma hematobium. Okay. This is the one that infects the bladder. You can have Schistosomia japonicum. This infects the liver and small intestine. And finally, you can have Schistosomia mansoni. This is something that infects the large intestine. Okay. What we are bothered about is the Schistosomia hematobium. Now coming to the life cycle of this Schistosomia hematobium, it can have 2 hosts. Okay. So there is a definitive host and there is an intermediate host. Now the definite host is the man. Okay. Whereas the intermediate host is the snail. Now let's look at the life cycle of this Schistosomia hematobium. Okay. Let's look at the life cycle. Let's assume that the man or the definite host is already kind of infected with this Schistosomia hematobium. So this has a special affinity to the blood vessels, and this is basically the venous plexus of the urinary bladder. Okay, venous plexus of urinary bladder. Now this Schistosomia hematobium, which is inside the bladder, will start multiplying. It will produce eggs, and these are kind of excreted in the urine. So when they are coming out, they become what we call as a miracidium. Okay, miracidium. Now this miracidium infects the snails. Okay. It infects snails. Now these snails, once they are infected, they give out certain larvae. And that is called as the cercaria. Okay, that is called as a cercaria. So these are basically mobile larvae. Now this is what is important. See, snail is something that's found in a moist environment. So if you go to a rainforest, walk around and stuff like that, so that is where you can get infested with this particular larvae. Now these larvae enter the patient through the skin, through the transcutaneous route. That is important. Okay, it enters via the transcutaneous route. Through the transcutaneous, that means through the skin it enters the patient, and once it enters into the bloodstream, it will eventually find its way to the venous plexus of the urinary bladder, and then this entire cycle continues. Okay, so this is basically the life cycle of Schistosomia hematobium. Now let's look at the clinical features that these patients come to you with. First of it is the swimmer's itch. So as soon as this cercaria kind of enters into the skin, it will cause immense urticaria. Okay, there is a lot of itching in and around that area. This usually lasts for about 5 days, and this is from the time the larva enters into the skin via the transcutaneous route. Next is something called as the Katayama fever. So please remember that all these larvae that enter the body have certain antigens in it. Okay. Now, if they have antigens, there is always a risk of some sort of immune reaction with those antigens, or some sort of hypersensitivity reaction with these particular antigens. So in this scenario, it's usually a hypersensitivity reaction. Okay, and this is not seen immediately. This is seen at a slightly later stage. Now, when I say later stage, it's usually about 4 to 12 weeks later. These patients can have high-grade fever, sweating, leukocytosis, and eosinophilia, and this is what we call as a Katayama fever. Second thing is, from the bladder, when they keep releasing the ova, that can lead to intermittent, painless, and terminal hematuria. As and when those ovas are released, the patient can have intermittent, painless, terminal hematuria. So how do we diagnose this particular condition? First and foremost, we will do a urine analysis. Now you need to know how are we going to collect this specimen of the urine. Now this urine that we are going to collect should usually be the terminal urine. Okay, that is why we said terminal hematuria. So we need to collect the last few ml or the last few drops of the urine that comes out, and that also specifically a early morning urine sample. So last few drops of an early morning urine sample is what we are going to collect, and in that particular sample you should be able to demonstrate parasite, eggs, or the ova. Okay, that means your cercaria, the larva or the eggs, you should be able to demonstrate them whenever you do a urine analysis. Now I told you that these are antigenic, that means they have certain antigens in them. So you should also be able to try to identify those antigens. Now that you will perform an ELISA test to look for the antibodies that have been formed against the Schistosoma mansoni. Okay, here they have something called as an adult microsomal antigen. So you should be able to find antibodies against Mansonia adult microsomal antigen. Okay, that is called as a MAMA. Okay, so that is what we are trying to identify whenever we perform a ELISA test. Next, when you do a cystoscopy, okay, if you want to put a camera inside and see, you will be able to see certain nodules and sandy patches that are usually present on the dome of the urinary bladder. And this is a very important image based questions. If you do a X-ray of the KUB, you will be able to see a fetal skull in pelvis appearance. So what happens is this Schistosomia hematobium can lead to chronic inflammation or chronic irritation. Now this chronic irritation will kind of trigger some sort of fibrosis and calcification. So eventually the patient will have bladder calcification. Okay, bladder calcification. So this Schistosomia hematobium or the Schistosomiasis is the most common cause of bladder wall calcification, and that is what gives rise to your fetal skull appearance. Okay, so if you see here, you're able to see kind of thin line there. Okay, that kind of resembles a fetal skull. That's why it's called as a fetal skull in pelvis appearance. The same thing you can see one more here, but in reality it is nothing but calcification. So how are we going to treat these patients? Of course, antiparasitic drugs, praziquantel, that is 200 mg dosage, and this you will give 3 doses. Okay, a single dose like how we give for deworming is not sufficient. You have to give them 3 doses. Apart from that, you can even give them metryphenate. Now, this schistosomia can have certain complications. One, it can develop urinary calculi. Because of chronic inflammation, they can have stricture which is induced by fibrosis, and long-term chronic inflammation or irritation can lead to cancer, bladder cancer, and these cancers are usually transitional cell or squamous cell carcinoma of the urinary bladder. So this was about the schistosomiasis of the urinary bladder. Next condition we are going to talk about is the Malakoplakia. So Malakoplakia basically means you are going to have a patch or a plaque inside the urinary bladder. Now here there is a chronic inflammation going on inside the urinary bladder. So why is there a chronic inflammation? See, normally if some bacteria gets inside the body, our defense mechanism takes over, it kind of kills the bacteria, phagocytosis happens, and then it is going to throw it out. Okay. Now let us assume your immunity is good, it has started to act on that particular bacteria, but it is unable to kill the bacteria. So there is chronic inflammation, chronic irritation going on, but the bacteria is unable to kind of being thrown out of the body. Now the bacteria doesn't go out, the inflammation will persist. So the inflammation persists, it can cause certain issues to the patient. So in this particular scenario, there is defective phagocytosis of macrophages and there is inadequate killing of bacteria. That is why there is a persistent continuous inflammation going on, and this disease can also affect the kidney and the ureter also. Now if you look at risk factors, very simple. I told you if your immunity is good, you will be able to kill the bacteria and throw it out. So if your immunity is bad, that means if there is an immunocompromised state like diabetes, transplant or post-transplant patient, rheumatoid arthritis, lymphoma, in all these patients, this disease will continue or this inflammation will continue. Now, this inflammation, if it kind of keeps on going on, there will be a certain plaque-like formation, which is usually yellowish in color. That's why it's called as Malakoplakia. Plakia means plaque. So that's why it's called as Malakoplakia. What's important here is that microscopically, okay, once you take out that plaque and you see for it under the microscope, there are large histiocytes, and these histiocytes are called as the von Hansen cells, and inside these cells there are certain inclusion bodies which is called as the Michaelis-Guttman bodies. Okay, Michaelis-Guttman bodies. So this can be asked. Please remember, they might give you all features and say they have done a biopsy and this is what they find. What is a diagnosis? This is a Malakoplakia. And the organism which is commonly involved, or the organism which kind of keeps getting into the bladder and causing that inflammation, is E. coli. Okay, that is the E. coli. So these patients will have symptoms suggestive of UTI, increased frequency or urgency of urination. And if you look at the diagnosis, you will find a mass in the urinary bladder. Why? Because of the chronic inflammation that has been happening. And if you look at it, you will be able to see plaques in the kidney or certain structures in the ureter. All these are also noted. So if you look at the treatment per se, all you have to do is help the patient fight the infection by giving them antibiotics. So this will treat the E. coli infection, thereby you will be able to reduce this chronic inflammation that is going on. Now let's talk about interstitial cystitis. Now there is inflammation of the urinary bladder. So there is pressure that is built up inside the bladder. Now if this pressure keeps on increasing, it is going to cause stretching of the bladder and will cause bladder pain. Okay, so remember, bladder pressure, bladder pain, that is what we call as interstitial cystitis. Okay, bladder pressure going up leads to bladder pain. So here what's going to happen, there will be chronic pancystitis because of infiltration of lymphocytes and macrophages in the bladder wall. See, normally you're going to have smooth muscles which can stretch, which will allow the bladder to distend. But here, because of this infiltration by the lymphocytes and macrophages, they tend to become kind of shriveled up and rigid. They don't stretch. Okay, there is a loss of distensibility of the urinary bladder. There is a female predilection for this particular condition. And if you look at the features, because the bladder is kind of shrunk, the minute urine comes and tries to stretch the bladder, the patient will have pain. Like I said, increased bladder pressure, and if you try to increase it even further, it will cause stretching and it will cause bladder pain. Now this pain gets better once you pass urine. Of course, then the bladder tends to get collapsed a little bit, so the pain tends to get better. Now, like I said, there is chronic inflammation, so the bladder capacity reduces, leading to increased frequency of voiding urine. Now, if you perform a cystoscopy in these patients, you will be able to see a linear bleeding ulcer in the mucosa. This is especially in the fundus of the urinary bladder, and these linear ulcers are called as a Hunner's ulcers. So, how are you going to treat these patients? One is bladder distension. That means you will push something and forcefully kind of stretch the bladder. That is called as bladder distension under anesthesia. Or the alternate option is to do a dimethyl sulfoxide instillation. This will also help treat the patient of interstitial cystitis. Now let's talk about the urinary bladder tumors. Now these urinary bladder tumors can either be benign or they can be malignant. First, let's talk about the benign tumors, then we'll talk about the more important, the malignant bladder tumors. Of course, that is where majority of the questions also arise from. Now, with regards to benign tumors, what we will be discussing today is regarding the benign papillary tumors. These patients will have a FGFR3 mutation, and when you perform a cystoscopy, these lesions will appear as a single frond with a central vascular core with the surrounding villi. So, if this is a urinary bladder, they will have this frond-like appearance or a papillary projection that is coming out. Now, because it looks like a finger-like projection, now that is why it's called as a papillary tumor. Okay, the finger-like projection is called as papillary appearance. So, that is why it's called as a papillary tumor. Now, the mucosa on this particular papillary tumor is the smooth mucosa. Okay, if you look at it, it is a smooth mucosa. Then there is something called as kiss cancer. So, what does this mean? So, this is your frond-like appearance, correct? So, that is your frond-like appearance which is coming out of the urinary bladder. Now, this is in a distended bladder. What if the bladder collapses like this? Okay. Now, this frond-like tumor is an approximation with the opposite wall of the urinary bladder. There can be certain deposition of cells onto the opposite wall, and eventually the patient will develop a neoplasm on the opposite wall as well. Okay. So, if this gets deposited here, the patient will also develop a tumor on the opposite wall. That is what we call as a kiss cancer. So, where else have we heard this terminology kiss? Okay, where else have you heard about it? I am sure all of us know about kissing tonsils. Okay, in tonsillitis, when both the tonsils are enlarged to such an extent that they are almost kind of occluding the airway, and they are also kind of blocking, or they are almost in contact with each other. That is what we call as a kissing tonsil. The second thing is kissing ulcers. Kissing ulcers. So, this is seen in the duodenum, especially D1. You can have an anterior ulcer, you can have a posterior ulcer. Anterior ulcers perforate, posterior ulcers bleed. So, these two ulcers, if they are approximating each other, okay, or if they are in close proximity to each other, we are going to call this as a kissing ulcer. So, same way in urinary bladder tumors, you will find the kiss cancer. Okay, where the frond-like projection is kind of sitting on the opposite wall, and there are certain deposition of cells on the opposite wall, which eventually becomes a tumor that side. Now, let's talk about the malignant urinary bladder tumors, of which we will be discussing about the carcinoma of the urinary bladder. So, now if you look at it histologically, okay, histologically, there are three subtypes that you guys should know about. First is your transitional cell carcinoma, second is squamous cell carcinoma, third is adenocarcinoma. Of this, the most common is your transitional cell carcinoma. Okay, this is the most common, followed by squamous cell carcinoma, and the least common being the adenocarcinoma. So the most common histological subtype is transitional, followed by squamous cell carcinoma, and the least common being the adenocarcinoma. Now let's talk about the risk factors. Now these risk factors are different for transitional, they are different for squamous cell, and they are different for adenocarcinoma. Now if you look at the risk factors for transitional carcinoma, here exposure to aromatic amines, family history, that means if there is family history of bladder cancer, then the risk is 2 times more, the risk is doubled, okay, 2 times higher risk of another person in the family developing a bladder cancer. Smoking itself is a risk factor for bladder cancer. However, they have said that if they have cessation of smoking for 15 years, okay, for 15 years, then the risk becomes equal to normal population or the non-smokers. That is what they are trying to tell you. Okay, so just by stopping smoking for, let us say, 1 or 2 months also is not sufficient. It will probably get your condition better to tolerate anesthesia, so on and so forth, but the risk per se of developing the cancer is not there. So if that risk has to come back to that of a general population, then you have to stop smoking for at least 15 years. Second is if the patient is on certain chemotherapeutic drugs such as cyclophosphamide. Cyclophosphamide can cause hemorrhagic cystitis. Now this is again chronic inflammation, chronic irritation can lead to malignancy. Apart from that, you can have dye exposure, that is the aniline dyes, or certain occupational exposure such as exposure to textile dye, exposure to rubber or petrol. Basically people who are working in these industries, they are at a higher risk of developing transitional cell carcinoma. Now also history of analgesic abuse, schistosomiasis, recurrent UTI and exposure to radiation, all these are risk factors for developing transitional cell carcinoma. On the other hand, again schistosomiasis, which causes chronic inflammation, okay, chronic inflammation, this is a risk factor for developing squamous cell carcinoma. At the same time, chronic irritation because of an indwelling catheter or a long-standing urinary tract stone or a bladder stone can lead to development of squamous cell carcinoma, whereas adenocarcinoma is usually seen in the remnants of the urachal duct or the urachal sinus, okay, or basically the urachal remnants. That is where you can expect to find adenocarcinoma. Coming to the genetic mutations, P53 and retinoblastoma, these are associated with high-grade tumors. High-grade tumors, that is the first thing. Second thing, they are more commonly associated with the muscle-invasive bladder cancer. Muscle-invasive bladder cancers. On the other hand, the FGFR3 gene mutation, these are more commonly associated with the non-muscle invasive bladder cancers. Bladder cancers. On this note, please note that grade is one of the most important prognostic factor. Okay, that is one of the most important prognostic factor in determining the outcome of bladder cancer. Okay, it is even more important than stage. Okay, grade plays a more important role compared to stage of the tumor whenever it comes to prognosis of that particular patient. So remember, P53 RB or the retinoblastoma gene is associated with high grade tumors or muscle invasive bladder cancer, whereas your FGFR3 gene mutation is associated with the non-muscle invasive bladder cancer. Now, the presentation of these patients are quite straightforward. They will come to you with gross hematuria. They can come to you with malignant cystitis. What is this malignant cystitis? Nothing great. Okay. Cystitis basically means inflammation of the bladder. Correct? Inflammation of the bladder. Commonly, we use the term cystitis whenever it is because of an infection. Okay, whenever it is because of an infection, that means UTI, urinary tract infection. But if that cystitis is because of malignancy, that means because of a tumor sitting there, which is leading to the inflammation of the bladder, then you're going to call it as a malignant cystitis. Nothing great about it. Okay, so if the inflammation is because of the presence of malignancy in the wall of the urinary bladder, then you're going to call it as a malignant cystitis. Now, certain times what will happen is, this is a urinary bladder, this is a ureter. Let us assume the tumor is in this particular area, all good, all fine. But there is a chance this tumor can grow in size and can occlude the ureter. So, if this ureter gets occluded, what is going to happen? It will get dilated like this. Okay. So, the patient can come to you with hydroureteronephrosis or hydronephrosis, and this ureteric obstruction, okay, that can get blocked. So, whenever there is hydroureteronephrosis, the patient will come to you with loin pain. Why? Because of stretching. So, there will be loin pain. Now, if the urine which is in this dilated segment gets infected, or the urine in the upper urinary tract gets infected, then what does it lead to? It will lead to pyelonephritis. That means inflammation and infection of the upper urinary tract. Moving on to investigations, first thing you will do is a urine routine. Now, in the urine routine, you are basically looking for malignant cells. Okay, you are looking for the cytology for malignant cells. Now, this is commonly positive whenever it is associated with the transitional cell carcinoma. Okay, not with squamous, not with adeno, but transitional cell carcinoma. That is because these urothelial cells, okay, the urothelial cells have poor cell adherence. Okay, they have very poor cell adherence. That means they don't adhere to each other. These cells will start falling into the urine. It can get shed and it can get collected in the urinary bladder. And whenever the patient voids urine, you will be able to identify these malignant cells. Now, this particular cytology of the urine, that is classified based on the Paris reporting system. Not important, you guys need to know the name. Okay, it is based on the Paris reporting system. Now, the whole idea about urinary bladders, okay, and its management depends on one particular thing, whether it is a muscle invasive bladder cancer or it's a non-muscle invasive bladder cancer. We'll talk about it in some time. Okay, so the whole idea is to try to differentiate it between the two. Now, if given an option, which is a better investigation between an MRI and a CT to look for invasion of the muscle? Now, muscle is a soft tissue, correct? So, in such a scenario, the best investigation will become an MRI. Okay, MRI. This is the best for local staging. Local staging. Why? That is because we are trying to differentiate between a muscle invasive bladder cancer and a non-muscle invasive bladder cancer. CT scan is basically to look for spread to lymph nodes. This is for staging. Okay, staging, to look whether it has gone to the lymph nodes, to the adjacent organs. All that information you will get to know with the help of a CT scan. And then there is something called as TURBT. Now, this is a more definitive form of diagnosis. This also acts as a therapeutic modality. So, I will just quickly run through this. We will talk about it in some time. Transurethral resection of bladder tumor. That is what it stands for. Okay, transurethral resection of bladder tumor. So, what we do here is, we go inside the urinary bladder, we take out the tumor and we take a biopsy from the base. See, MRI might tell you that it is not a muscle invasive bladder cancer, but however you so sure that it has not invaded the muscle. Okay, so you're going to take a deep biopsy, and this is what is the confirmatory way of telling whether it is a muscle invasive or a non-muscle invasive bladder cancer. Because sometimes MRI can underestimate the disease, it can even overestimate the disease. But what is accurate and what is more certain and more dependable is your TURBT, that is a transurethral resection of the bladder tumor. Apart from that, there are certain other investigations that will help you identify or diagnose a bladder cancer. One is your urinary biomarkers. Here you will be looking for NMP22 or Eurovision. Second, you can perform a cystoscopy. Now in cystoscopy, you have a white light cystoscopy and a blue light cystoscopy. What we will be using here is the blue light cystoscopy, where you will be using a light of a different wavelength, which will give you a sort of fluorescent imaging. Okay, you will get some sort of fluorescence, and that is what you are looking for. Apart from that, you have narrow band imaging. So in narrow band imaging, what do? We use light of two different wavelengths. Okay, one that is absorbed superficially and one that is absorbed by the deeper tissue. Okay, so light of two different wavelengths, and both these lights have a lot of affinity towards hemoglobin. Okay, increased affinity to hemoglobin. Okay, increased affinity to hemoglobin. So basically what happens here is, wherever there is more blood, there is more hemoglobin. So that light is taken up more in that area, so that area will become very bright. Okay, you'll start seeing it like a bright patch in that area. So in short, whenever there is malignancy, okay, we know that the blood supply to that area will be very high. That means it is a hypervascular region. Hypervascular region. So that means more is the light that is taken up, and this area will kind of light up and will become very bright, and that will tell you that area is neoplastic. Okay, now this is done for doubtful cases, not when you have an obvious tumor sitting there. Then you don't need all this blue light, white light, all this is not necessary. You can directly look at it and do your TURBT and get out. Okay, in there is doubtful cases or carcinoma in situ sort of scenarios, that is when you will use all this blue light cystoscopy and the narrow band imaging. One other thing that is mentioned in your books is this bimanual examination. That means in females, okay, 2 fingers in the vagina and 1 in the suprapubic space. In males, 1 finger in the rectum and the other hand, okay, or the opposite hand in the suprapubic space, and you're trying to see if you can feel the tumor. This is all olden days, not used much nowadays. Okay, now because we have much more reliable investigations in the form of CT or an MRI, which can exactly tell you where the tumor is, how much it is spread, so on and so forth. But earlier days, when they didn't have the luxury, they used to depend on this bimanual examination. So by doing a bimanual examination, if you are unable to feel the tumor, that means if it is non-palpable, it is less than T2. Less than T2. Okay, we will talk about what T1, T2 is in some time. If there is induration, that means it is at least T2B and beyond. Okay, at least T2B. If there is induration, that means you can't feel a mass, but you can feel some sort of induration there, that is T2B. But if you can feel a mass, okay, if you can feel a mass and it is mobile, then that means it has come outside the bladder, it has formed a tumor and you are palpating the tumor. That is what it means. That means it has come outside the bladder. So that means it has reached the extravesical space. Okay, extravesical space. This is T3. And the tumor is fixed, that means it is no longer mobile. Earlier at least it was mobile, now it is fixed, it's no longer mobile. Then this is categorized as T4, where it kind of goes and gets adhered to either the lateral pelvic wall or the adnexa, so on and so forth, and it becomes a fixed tumor and it is not mobile. So that was about the bimanual examination. Now a little bit more about this transurethral resection of the bladder tumor. Okay, we've already discussed this, but we'll just quickly run through it. Now the advantage of doing this TURBT, one is you will get a histological diagnosis. That means you will get to know whether it is a transitional cell carcinoma, squamous cell carcinoma, or an adenocarcinoma. Okay, so that information you will get whenever you perform this TURBT. Second is, like I said, it will give you a more confirmatory diagnosis whether the underlying muscular layer is involved or not in doubtful scenarios. Sometimes in the MRI you can see that it is obviously gone or it is very superficial. That information you will get. But certain dilemma in that gray zone, okay, where it is very close to the muscle, you don't know whether it is involved or it is still not yet involved. So that is when a biopsy from the base will exactly tell you whether the deeper muscular layer is involved or not. And whenever you do a TURBT, please remember you are doing it like a therapeutic surgery. So you need a 2 centimeter margin. Okay, you need 2 centimeter margin. And another point with regards to this TURBT is something called as the obturator jerk. So what is the obturator jerk? So there is an obturator nerve, correct? I'm sure all of you know that we have this obturator nerve in the body. Now this is adjacent to the bladder. Okay, like for example, if this is a urinary bladder, the obturator nerve is in close proximity. So whenever the bladder is distended, okay, whenever the bladder is distended and you are operating on a tumor in this region, whenever you are using your electricity through your electrocautery, this nerve might get stimulated and you will have a jerk, you will have a sudden jerk. That is what we call as a obturator jerk. Now the danger is when you are doing that, if it jerks, there is a chance you can perforate the bladder. Okay, you can perforate the bladder. So how are you going to deal with such a perforation? If it is a large perforation, convert that to a laparotomy and close the defect. But if it's a small perforation, a tiny perforation, then all you have to do is put a catheter, leave it for some time. So basically an indwelling catheter, you're going to leave it there and that small perforation will heal off by itself. That is the idea. Now how do you prevent this from happening? Okay, now we learnt about if it perforates, how to correct it, but you also need to know how to prevent the perforation in the first place. So what they suggest is use a partially filled bladder. Don't distend it so much that it goes and it's kind of adherent to the obturator nerve. Keep it slightly less distant, so you'll have enough space. More so when you're operating on the lateral walls, because that is where the obturator nerve comes. Anterior, posterior doesn't matter, very unlikely to get a jerk. But whenever you're operating in the lateral wall, try to keep the distension slightly less. So if you don't distend the bladder too much and there is a minimal or a moderate distension, it tends to be far away from the nerve. Thereby you can avoid this obturator jerk. Second is to use bipolar diathermy rather than monopolar diathermy. Use a bipolar diathermy, then also the risk of this obturator jerk is less and the risk of perforation is less. So this is an image of a transurethral resection of the prostate. You can see this is the resectoscope. Basically it is an addendum to your cystoscope. You go in, you find the tumor, identify it, remove that tumor and you're going to come. This is what is your TURBT. Now let us zoom into this area and look at it better. So once you zoom in, you will see that there is a tumor sitting there. Now you will use a surgical loop which has either a bipolar or a monopolar diathermy. And like I said, if you want to avoid obturator jerk, use a bipolar diathermy. Okay, using your surgical loop, you will go in and you will remove the tumor and you will come out and send it for histopathological evaluation. And what is the margin you need to take? 2 centimeter margin. Remember that, 2 centimeter margin. So initially there will be a raw surface there. Eventually that will get epithelialized or it will get covered with the help of a scar tissue. Now moving on, let's look at the staging. Okay, the TNM staging of your bladder tumors. And like I said, in bladder tumors, the most important is to differentiate between a non-muscle invasive bladder cancer and a muscle invasive bladder cancer. Why is this important? See, if it is a non-muscle invasive bladder cancer, they say just a TURBT is a sufficient surgery. Okay, a TURBT is sufficient because you have removed the entire tumor. Whereas if it is a muscle invasive bladder cancer, the minimum surgery you have to do is a cystectomy. Cystectomy, that means you have to remove the entire urinary bladder. That is what they are trying to tell you. Okay, so it's a big difference. If you see, one is just like a cystoscopic surgery, the other one is to remove the urinary bladder completely. Okay, so there is a huge difference between the two procedures, and that is why you need to know what is the exact cutoff, and that is why you are always struggling to find out whether this is muscle invasive or a non-muscle invasive. Now let us try and understand why that is. See, when they say non-muscle invasive, that means it has not gone into the muscularis layer of the urinary bladder. It is still in this subepithelial connective tissue. That is what is your T1, that is the lamina propria. Now what they believe is, the minute the tumor reaches the muscle, it can send out cells, because the muscle is a very vascular organ. It can send out these malignant cells into the bloodstream, and this can go and get metastasized, or it can go and sit in the adjacent lymph nodes. Okay, that is what they are worried about. See, in the first scenario, all you have to do is remove the tumor and come out. Whereas in the second scenario, just removal of this tumor is not sufficient. Who is going to deal with this? Okay, so in such a scenario, it is better to do a cystectomy and a lymph node clearance. I hope you're getting the point. So anything beyond this T2, okay, anything T2 and beyond, a TURBT alone will not suffice. You have to do a radical cystectomy. Okay, that is why we are kind of hell-bent on dividing it between the non-muscle invasive and the muscle invasive bladder cancer. Now the cutoff for that is, like I said, T1 is non-muscle invasive, T2 and beyond is your muscle invasive bladder cancer. So this is your TNM staging. T0 means no evidence. TA is non-invasive papillary carcinoma. TIS is carcinoma in situ. T1 is tumor which invades the subepithelial connective tissue layer. T2 is it goes into the muscle where A is superficial, B is a deeper muscle of the urinary bladder. T3 is if it invades into the perivesical tissue where it is microscopic if it is A and macroscopic if it is B. And T4 is where it starts going into the either of the following structures such as prostatic stroma, seminal vesicles, uterus, vagina, pelvic wall and the abdominal wall. T4A involves the prostatic stroma, seminal vesicles, uterus and the vagina, and the T4B, the tumor involves the pelvic wall or the abdominal wall. Now quickly, anything about this on bimanual palpation, you will not find anything. If you find induration, that means it is T2. Okay. If you find a mass but it is mobile, then it is T3. If you find a mass that is fixed, then it is T4. That also preferably your T4B. Why? Because that is the one which is adherent to the lateral pelvic wall or the abdominal wall. Coming to the end staging, N1 is metastasis in a single lymph node in the true pelvis. N2 is metastasis in multiple regional lymph nodes in true pelvis. N3 is metastasis to the common iliac node. And again, M is where you're looking at metastasis. M1 is non-regional lymph nodes and M1B is other distant metastasis. Okay. Coming to carcinoma in situ. Now this carcinoma in situ, as the name suggests, it is an in situ cancer. That means it's a non-invasive cancer. Okay. Where it is restricted to the bladder wall and it is present with malignant cystitis. That is the most common presenting feature with carcinoma in situ. So when you do a cystoscopy, the mucosa may either be normal or it may have erythematous patches. So this is where all your narrowband imaging, blue light cystoscopy and all come into picture. Why? Whenever there is a doubtful picture when you do a cystoscopy. Now let's look at the management. Again, management you have to divide it into two things. Non-muscle invasive bladder cancer. Okay, non-muscle invasive bladder cancer and muscle invasive bladder cancer. Now in non-muscle invasive bladder cancer, TA, okay, so for TA, all you have to do is TURBT, and you will have to give them perioperative chemotherapy. Okay, and this chemotherapy need not be IV, it can be a chemotherapy which acts locally, and the treatment of choice is mitomycin C instillation. That means do a TURBT and within 4 to 6 hours you will instill mitomycin C inside the urinary bladder. That is what kind of kills off whatever remnant cells are there, and that will give you a good prognosis. Okay, a good prognosis going ahead. Coming to T1, here TURBT you will do, then again recheck after 6 weeks. If there is residual disease, what will you do? You will do a cystectomy. Okay, if there is residual disease, consider cystectomy. If there is no residual disease, then you can consider the intravesical installation of BCG. So here this will become perioperative immunotherapy, not chemotherapy, because BCG comes under immunotherapy. Next, this carcinoma in situ, remember the intravesical BCG is given after 6 cycles, and then if residual tumor is there, then you will go ahead and perform the cystectomy. That is what we just discussed. Moving to T2, this is your muscle invasive bladder cancer. Muscle invasive bladder cancer. So T2 means it is still in the muscle layer. Okay, it hasn't gone outside the urinary bladder. That means it has not gone to the extravesical tissue. So here first thing you will do is you will give them a cisplatin based neoadjuvant chemotherapy followed by radical cystectomy and a urinary diversion. Why are we doing a urinary diversion? Because the entire urinary bladder is out. So you have to do something to make sure the urine from the kidney that is formed is going outside the body. So you will eventually end up doing a urinary diversion. So if they ask you which is the most common, then it is the ileal conduit. Okay, ileal conduit. Now for T3 and T4 tumors, these are usually non-operable or inoperable tumors that you are dealing with. So again, these patients are candidates for neoadjuvant chemotherapy. Okay, they're candidates for neoadjuvant chemo. Then if it shrinks and becomes operable, then do a radical cystectomy. Coming to these intravesical agents, like I said, it can either be chemotherapy or it can be immunotherapy. Chemotherapy, you have mitomycin, thiotepa, adriamycin. Whereas for immunotherapy, you have your BCG. See, these you will give within 4 to 6 hours. 4 to 6 hours after surgery. Okay. Whereas BCG you will give 4 to 6 weeks later. That is because when you have done a TURBT, you will have raw surface. You will have a raw surface. Do not give BCG whenever you have a raw surface or whenever there is a wound. Allow that wound to heal. Now the time taken for healing is about 4 to 6 weeks. After that you give BCG. Don't give it before that. Okay. Before that, if you want to give chemotherapy, not immunotherapy in the form of BCG. And the same thing is indirectly told that if there is hematuria, don't give BCG. If there is hematuria, means there is a raw surface somewhere, so don't give BCG. So BCG should be given only when the wound is completely healed, and that will usually take about 4 to 6 weeks. Now, what are the absolute contraindications of BCG installation? If there is immunosuppression, if there is history of BCG sepsis, if there is macroscopic or gross hematuria, if there is a complete or a total incontinence, early post-TUR or traumatic catheterization, wherever you think there is a raw wound, better to avoid BCG. Okay. Now, when it comes to relative contraindications, urinary tract infection, liver disease, history of tuberculosis, advanced age, poor performance status, all these are relative contraindications for installation of the BCG. Coming to the chemotherapeutic drugs, there are 2 regimens. One is the MVAC regimen and the other one is the cisplatin and gemcitabine regimen. Under MVAC regimen, M stands for methotrexate, V for vinblastine, D for doxorubicin or adriamycin. and cisplatin. So that is your MVAC regimen. Apart from that, the alternative is to give them cisplatin and gemcitabine combination. Coming to urinary diversion, like I said, you have removed off the bladder. So the two ureters have to be anastomosed somewhere. One option is uretrosigmoidostomy. That means your kidney is here, the ureters are here. Okay. Your sigmoid colon is coming like this and then becoming the rectum. Correct? So this is your sigmoid colon and then becoming the rectum. So what they did is they brought these two structures, the two ureters, and they implanted it inside the sigmoid colon. Okay, so basically urine was coming inside the sigmoid colon and then getting out. Now the problem is this area there is constant irritation because of the toxic elements of the kidney. Okay, now it is the kidney elements which are causing irritation and problem to the colon. So this patient is at a higher risk of developing adenocarcinoma at the anastomotic site. Second thing is colon is an area where there is a lot of bacteria. Now this bacteria can go up the urinary tract and cause pyelonephritis. So it can cause a retrograde infection and cause pyelonephritis. Apart from that, these patients can present with hyperkalemic, hypokalemic metabolic acidosis. Okay, where chlorine is more, potassium is less, and the patient has metabolic acidosis. That is found in uretrosigmoidostomy. Next urinary diversion we are going to talk about is the ileal conduit, and this is the most commonly used technique. Okay, or the most commonly used conduit. So here what they will do is they will take a small segment of vascularized intestine, and that is used to create the ileal conduit. So one side they will close and attach the ureter, the other side is brought out as a stoma, and the urine will come out of the anterior abdominal wall. Okay. So this is an image of an ileal conduit. Here you can see the bladder is removed. So the two ureters are anastomosed to a vascularized piece of the ileum. And this ileum is brought out as a stoma, and all the urine from here will keep coming out of the stoma. Now this particular conduit can either be continent or an incontinent ileal conduit. Okay, continent or an incontinent ileal conduit. Now continent means where the urine will kind of sit inside. You have to do a clean catheterization to empty the bladder. Okay, this is your Cox continent ileostomy. Incontinent means it is directly there and there will be constant flowing of urine. As and when the urine comes, it will flow out. That is what we call as an incontinent ileostomy. Last thing we are going to talk about is the neobladder. Here the small portion of the intestine is made into a bladder, and on one end it is attached to the urethra and the other end they will attach the ureters. So if you look at this particular image, so what they have done here is they have taken out the bladder, okay, or a big chunk of the bladder is removed. Then they kind of took out one segment of the ileum. That ileum they opened and they stitched it up to the urinary bladder. Okay, and if you need length you can even use the appendix, but nothing much. The idea is they have tried and covered the urinary bladder, and this is how it's going to look after surgery, where you will have a small patch in the center of the urinary bladder. That is where you have used your ileal segment. Okay, this is what is normally there. So with that we come to the end of this module. A very important module, but then again a lot of factual questions which sometimes you have to mug up, but otherwise it's a relatively straightforward and easy module. So study well, revise well, all the very best, and I'll see you soon.